Assalamu alaikum doctors. In this video I am discussing about ITP, idiopathic thrombocytopenic purpura. So ITP, what are the features we can find? There is purpura. Look at the purpura features: bruising and petechiae. So petechial rashes, purpuric rashes and bruising. Again, petechial rashes, purpuric rashes and bruising. Other symptoms include bleeding from the nose and the gums, black blisters in the mouth. Okay, there is heavy menstrual periods and fatigue. And child is active, ITP, there's a history of upper respiratory tract infections like 1 week or 2 weeks back. ITP acute, we can tell 0 to 3 months, persistent 3 to 12 months, and chronic is more than 12 months. Again, 0 to 3 acute, 3 to 12 is chronic, and more than 12 is persistent. The differential diagnoses are ITP, henoscalin purpura, hemolytic uremic syndrome, we can non-accidental injury, meningitic, meningococcemia, DIC. We can go for drug reactions, anaphylaxis. These are sepsis and periodic inflammatory multisystem syndrome, PIMS. History, what we ask: first of all, onset, course and durations, anything make it better, anything make it worse. And the rash itself, like is it blanchable, non-blanchable, the rash, distribution of the rash, there is distribution of the rashes, painful or painless, itchy, non-itchy, bleeding from any other orifices. These are so is that before what happened, any preceding upper respiratory tract infections, non-blanchable, headache, and other orificial bleeding, red spots in the mucous membrane or eye, sign suggestive of malignancy. So sign suggestive of malignancy, that is abdominal distension, hepatomegaly, splenomegaly, other family member or sick contact. If registered to the social service, NAI, DD, we can ask. So these are the history we ask. Examination, I will do the airway, breathing, circulation, dehydration status, the temperatures, rash package, CNS, fundus, mucous membrane, and abdomen lymph nodes. Investigation, what we do: full blood count, coagulation profile, blood grouping, blood film, virology screening, bone marrow if a suspect malignancy, CT brain if neurological symptoms. So full blood count, blood grouping and cross matching, blood film. We do the lymph nodes examinations. We do the CT of the brain investigations because of any neurological symptoms, and bone marrow if suspect malignancy. Then management, if the only petechial rashes, no bleeding, so reassurance. Only some rashes, no bleeding, reassurance. Then mild, moderate and severe bleeding. What are the treatment we give? Mild, we are giving the tranexamic acid, antifibrinolytic and adjuvant treatment to control the bleeding. Moderate, we are giving prednisolone and IV immunoglobulin. And severe, we are giving prednisolone, IV immunoglobulin, and prednisolone, IV immunoglobulin and tranexamic acid, and also steroid we are giving. These are platelet these are severe, we are giving platelet transfusion, methylprednisolone and IV immunoglobulin. Again, I am telling the treatment. Mild, we are giving tranexamic acid. Moderate, we are giving the prednisolone and IV immunoglobulin. Severe, we are giving platelet transfusions and methylprednisolone and IV immunoglobulin. Then if chronic ITP, what we do: the bone marrow study, prednisolone or dexamethasone, IV immunoglobulin, rituximab or thrombopoietin receptor antagonist. So rituximab and thrombopoietin receptor antagonist, and splenectomy plus advice. Examination, they ask you non-blanchable rash, if full blood count, blood film, what finding, abnormal differentiation, indication of bone marrow, why not NAI. So these are the questions they can ask. Mechanism action of tranexamic acid, it is antifibrinolytic and adjuvant treatment. Indication of bone marrow, when we do the bone marrow study: severe pallor, profound pallor, neutropenia, hepatosplenomegaly, lymphadenopathy and limb pain. So the bone marrow biopsy, first of all, severe profound pallor, lymphadenopathy, neutropenia, then lymphadenopathy, limb pain, hepatosplenomegaly. Splenectomy, when we do massive bleeding. Chronic ITP, and if medical treatment is failed, and hematology advice we take. So massive bleeding and chronic ITP, and there is medical treatment is failed, then we go the surgery. So what advice we give? The splenectomy, we give the splenectomy: avoid overcrowding, avoid NSAID, avoid infections, avoid strenuous exercise, contact sports, educate them. It can be recurrent and in 20% cases. So it can be recurrent in 20% cases. This is all about ITP. Another red flags: neck stiffness, can't move his limbs freely, toxic, high-grade fever, loss of consciousness, severe headache, pararectal bleeding, hematuria, joint pain and swelling. These are the red flags. Okay, neck stiffness, can't move his limb freely, toxic, high-grade fever, loss of consciousness, severe headache, pararectal bleeding, hematuria, and joint pain, swelling. Thank you.